Thank you, Verna. Assessing and managing a deteriorating patient is quite a challenge for us, and I'll probably be talking, well, not probably, we'll be talking about it probably with my acute oncology head, but also a chemo head on as well. So I think as the day's gone on, I think we're realising that our capacity and demand for chemotherapy and the supportive services are becoming increasingly pressured. Several reports have highlighted this. You've got the emergency admissions place an enormous burden on patients in the NHS, and in this role that I'm doing at the moment, predominantly I can probably spend about 2 hours at least a day in A&E working with the team. Over the last decade, emergency admissions have increased by 31%. We know that 1 in 2 people will have a cancer diagnosis at some point in their lives, and emergency presentations linked to cancer has doubled over the past few years, with 300,000 of unplanned admissions per year. So if you think of all the other long-term conditions we deal with, and we're dealing with generalist nurses that have very little experience about cancer and its complexities, it is quite a challenge. So why is this? So we've discussed earlier, or it has been discussed earlier, that we've got an increased life expectancy. We're meant to be living forever. I don't know whether I agree with that or not. I know over at Stoke Mandeville we've got 102 and 104-year-olds sat on the wards at the moment. You know, it's not going to be something that is unusual to us as time goes on. We've got new developments. We've heard all about those this morning and the complexities that they give the patients and the challenges they give to us. We've got more trials available for patients, which is absolutely amazing in some ways, but again, great for the patient, challenges for us, because if we're giving drugs that we don't really know what's going to happen to the patients, how are we meant to manage them? And greater use of palliative chemotherapy. I mean, we've got so many different drugs, so many NIBs and MABs and everything else, and they're all being combined now. It's trying to undo, it's like a ball of knitting that you're trying to undo when you're in A&E, trying to think, right, what is it? You know, and a clear example of that was yesterday I was in A&E and I had a patient that was on sorafenib telling the A&E junior doctor that it wasn't chemo. She was sat there with sepsis. So well, luckily I have big ears and I could just slide in. But again, it's like Catherine was talking about. It's what the patient perceives, what we want them to know, and how we educate them. I had a chemo book as well, but that was beside the point. I'm not quite sure why they're carrying that when they're not on chemo. And this poor doctor was quite confused. He couldn't work it out. So what do the patient thinks when we're looking at these deteriorating patients when they come in with their complex problems? Well, when they come into hospital, they put their trust in the health professionals looking after them. That's good, isn't it? And they expect to be monitored and any deterioration to be detected and acted on immediately. We all know when you're pressured, you're on the ground floor, that always doesn't happen, does it? We're not perfect, we wish we were. It's something to be mindful. It's about nursing care is meeting the patient's expectations. And I think if we can communicate that and say we absolutely try our best, you know, to get you through this, we may have some blips, I call them blips or moments, rather than challenges or anything else when I'm talking to the patients. You know, it'll be fine. We don't always get it right, but we do our best for you as much as we can. So, SACT. How many are there? We've already discussed today. There's hundreds of different treatments. How much do we need to remember? Lots. We're not going to remember it. We can't remember, you know, we remember times where we had to remember all our patients that came in the department. Now I'm looking, I think I know the name, but I can't see the face. And then I see the face, I can't see the name. You know, and it is huge. But what tools do we have as chemotherapy and those working in the acute oncology or hematology? Hematology does come with acute oncology. The hematologists have an issue with that, we don't. So it's quite interesting. So what tools do we have to help us in assessing these patients? Well, there's 3 main tools really from a chemotherapy, heme and onc point of view. We've got the news scoring, and I expect everybody to go, oh God, news scoring. It's always audited. Has it been added up properly? And then we've got the UCONS triage. So those two tools, do you all use on a regular basis? Do you use them in the way that they should be used? Really? I know there's been times I haven't, and I've been in a hurry. But the other services that are available to us, we need to use them. So they are so complex, these patients. Use the acute oncology service. You know, we are there around and about for advice. And from an A&E point of view, when these patients come into that area, we in Bucks have got an increased presence in A&E. So yeah, we do spend quite a lot of time in there talking, not drinking tea, talking, trying to suss things out. So the changing profile of the acute care requires nurses who are competent to respond effectively to the needs of the acutely ill. There's new nice guidelines from haematology that from this year, 2016, that actually all nurses in chemotherapy need to be looking at having advanced assessment skills to be able to assess these patients and identify early signs of deterioration, let alone when they come into A&E and we pick them up. And the role of the acute oncology nurse is actually about working in that environment. We like a collaborative approach, like to keep our clinical skills up as well as actually doing the advice as well. So if you're giving chemo, you're talking to your patients, you're hearing, you're educating. If you've got students, you're educating, they are hearing, you educate the patients. It's a real good collaborative role actually. What are our challenges? I think for those of us that are quite senior, would we get anxious about escalating? Probably not. But your band 5s and your junior band 6s will definitely get anxious about escalating. Some of it's about boundaries. I should know this, but I don't know what to do about it. Rather than say, actually, I don't know, I'm going to ask somebody that can. I think where you're in a high-risk area to do with oncology and chemotherapy, I think the best thing is, hands up, I don't know, I'm finding somebody that I can. Also, the frequency and exposure to deterioration. I mean, I'm talking with chemo in an acute oncology head-on, but if you go out on the wards, there's cancer patients dotted around everywhere, and the generalist nurse might not have that frequency or exposure to a complex cancer problem. Knowledge and skills, we grow those as time goes on, and actually the more we're exposed to stuff, the more knowledge and skills we've got in our bank with our clinical areas. And prioritising workload. All busy? Patients looks absolutely fine. In fact, most of the patients look better than we do when we see them. However, you know that underneath that there's potentially quite an acutely unwell patient that could just deteriorate very, very quickly. So we do need to look at our workload. We can get too busy, but we need to be mindful. What you see is not what you get with a cancer patient. And about difference of opinion. Got a patient in, maybe with bowel obstruction, but there might be some other medical issues. You've got a surgical opinion, you've got a medical opinion, you've got an oncology opinion, and there you are trying to negotiate the best pathway for that patient to be on, whilst making sure that they are stable in their condition. And then we can look at defined deterioration. It says to become worse, but what is worse? Really? I mean, they've got cancer. The patient thinks it can't get any worse than this. Well, unfortunately, you can, from our point of view and yours. So it's really looking at what does that patient understand by becoming worse? What do we understand by becoming worse? So what are we going to do about it? That's the only bit of artwork I can do on a computer. I was quite impressed. It took me 20 minutes. So we've got UCONS triage. It always comes up a bit fuzzy when you do it like this. So you've got a patient out in the community, they phone the triage practitioner if they're doing what they're told and they've not left it too late. So triage practitioner can be anybody that's chemotherapy trained. It may be that telephone number comes through to a chemo unit. It may come through a triage line like they have at Oxford. We're just developing our triage line at the moment. Well, end of year. I don't like tight deadlines. And we've got our triage log sheet. So you've got, as similar to Catherine's, we've got attend for assessment, we've got review 24 hours if it comes up an amber, and we've got advice and reassurance. Now, our UConn's triage sheets are uploaded onto Evolve, which is our electronic note system. So actually, when you're filling it in, it actually, one, drops down all the patient's details, Brucey bonus, no stickers required. Also, it will actually highlight to you whether they need to come in, whether you need, for assessment, a 24-hour follow-up phone call, or whether you just need reassurance. Tickety tick, submit, sorted, highlight to who you need to. Using news. I used to hate this when this used, well, not, I hate's the wrong word. I used to find it irritating. It's like obs. I'm just an old-fashioned nurse. Does my head in. Why have I got to count it up? I'm not good at maths. However, that's right. However, temperature, heart rate, rests. I've worked somewhere recently where HCA put everybody's rests at 20. I thought that was classic. I did ask, was that really true? Because actually, if you look at the heart rate, if you've got rests of 20 and you look at the heart rate, it kind of goes together. It's interesting. And sometimes you rest your heart rate and your temp if the pyrexia will go together. So to have a standard thing of rest 20 on every patient that comes through the door, that could be 20, 30 patients a day, I felt that was quite a little good audit up here. Some education needed to be picked up. Systolic BP, level of consciousness, and O2 sats. What I would say about level of consciousness is sometimes when I'm seeing somebody in an acute environment like an emergency department, if you ask closed questions, and probably we all know this, if you ask closed questions, the patient will say no or yes, depending on what you've asked, but actually they haven't actually taken in what you're asking them. And one of the little things that I use, and I don't know whether anybody else does it, perhaps it's just me because I'm a bit weird, if I look at their eyes, they have a vacant look in their eyes. You can actually, when we talk with our eyes as well, and you can actually see their facial expressions, so you know whether a patient has taken the information in. Very interesting.
Call it observation, Emma.
It is observational. And I had an F1 actually. I liked a little story. I had an F1 on the ward. An elderly chap with brain mets came in confused. I had a call to say, could somebody review him because the family wanted to speak with him. I think he was about 70 or 80. And the F1 bless had said she had given him his diagnosis of lung cancer with brain mets and that he understood everything that she had told him about his disease, and she'd actually documented it in the notes. I went to see the patient and I said, who I was, and the blank eye, and he just went, yeah, and little eyes were a bit blank and a bit strange. Anyway, I said, you saw the doctor this morning, could you just reflect back to me what you did here? What did the doctor tell you? He said, I've come for an eye test. I went back to the notes and I said, and then tried to get my glasses off me. I said, no, they're mine, they're pink, leave them. So I then went back to the notes and said, please see above documentation, but you may want to revisit this patient's state of mind as it seems very confused at this point. And she'd just gone down a list of her questions, and it is about experience, really. I did feel a bit sorry for her, but, you can't ignore that. But in conjunction with your UCONs, your news, and with your comorbidities, so important, we don't write them down, current treatment plans and what their diagnosis and potential prognosis is, we can come up with an agreed treatment plan and document it, please. I know we all hate that word document, but can we just, it's not what you write, it's what you don't write when we're trying to investigate serious incidences. And how many of you guys use the performance status? Yep. So I would say standing where I'm standing at the moment, it'd be the minority rather than the majority. It's actually really important. on an e-prescribing system that we have over in Thames Valley, and I know that you probably have others elsewhere, if you can do a performance status at the before treatment or at your chemo chat and all the way through, when you are dealing with a complex issue and assessing and managing that patient, you can actually see what they were able to before and how they're doing during, and potentially if they come off their treatment. It really is fairly important, and I have to say I quite like it, because the patients tell you anything you want to hear, really. You know, some patients will just get up and cook dinner, and yet they've been up cooking dinner. You'd think they've been up all day, but actually they haven't. So pinpointing those precise bits of information you need to gather up what's happening with this patient. Some key points to remember, apart from your neutropenic sepsis and your diarrhea and your mucositis, of the acute oncology initial management guidelines 2015, is that chemotherapy toxicities can make a patient rapidly unwell. But if we assess and manage them properly, we can actually, most of them are reversible. Another key thing that we're not sometimes always very good at is monitoring their fluid input and output. What we put in needs to come out. That includes of litre bags of cisplatin. It may seem daft, but it can happen. And look at their albumin. If they're, if they've got advanced disease, we need to be looking at their albumin rather than, if they're not peeing it out, where's it going? And they're, their ankles getting bigger as we're giving their chemo, or we're giving IV fluids on the wards or in A&E. Someone's got an iPhone 6. And the other thing is looking at reviewing your concomitant medications. I said it, and consider stopping them, because they do affect the renal function. What does chemotherapy and cytotoxic or SACT drugs do? They affect your renal system. They can actually look at, they have an issue, or they can cause an issue with potential hypertension. Your ACE inhibitors, diuretics. And how many times do you think you can see a doctor write up IV gentamicin in an emergency situation whilst you're still waiting for the U's and E's to come back? I think we have got better at it, but it still happens. And it's just a consideration to be mindful of when dealing with these patients and assessing them. So we talked a little bit about escalation, but who should be contacted? Yes, it's us, the AOS team, and we've got medic, surgical, and also back to the patient's own onc and heme team. Oncology is a lot more easier than hematology, actually. Hemes are in a little special area of their own. They do their own thing, so you have to keep pulling them back to do what we need them to do. But even saying that, they do know their patients very well. In fact, they know them probably better than an oncologist. And the medical and surgical team. So a lot of collaborative working and communication. And the tumour site specific CNS, that's already been mentioned today. And the trials team, if on a trial. We forget them. We can have a reaction in Stoke Mandeville, and the trials team's next door. But do we go and say, just had and just about to go into anaphylaxis? No, we don't. And the amount of forms that they have to fill in is amazing for an adverse event, but we actually are not very good at doing that, so we just have to be mindful. And also, if we're stuck with really severe nausea and vomiting, sometimes diarrhea, call the palliative care team. They've got lots of tricks up their sleeves, actually, for advice. So we need to, use them and work with them. So I just want to pop into a case study, a real life case study about lessons learned. So this patient was referred for neoadjuvant chemotherapy, ECX, epirubicin, cisplatin, capecitabine, CA esophagus. I think they're probably about 65, if I remember. Gave cycle 1, marvellous, evidently. Call from patient on 3 days prior to cycle 2 regarding nausea and diarrhea. They called into the chemo unit, and they were advised to take their metoclopramide and their loperamide and call if no improvement. It's a 3-week cycle. Bloods were taken the day before. We didn't hear anything from that patient, and bloods were taken the day before, cycle 2, Newt showed 2.3. Normal. So I'll tell you what, let's go ahead and give cycle 2. 4 days post cycle 2, a call from the patient with severe diarrhea. The advice that was given was to see the GP and rehydrate. There's obviously documentation, there's lots of things going on here. We've got a patient with a normal blood, normal neutrophil count. We've got no other symptoms apart from diarrhea and a bit of nausea. There's one drug actually that really strikes out when you think about it. Advised to seek urgent medical help if deteriorates. 5 days post chemo, follow-up call from hospital. Patient has seen their GP, has diurolite, and the district nurse is taking blood tests. It's good. We need to be more proactive and assertive and really pinpoint our questions that we are asking these patients on the phone. I think if you're nauseous, diurolite actually is not very nice. Blood test taken by the DN showed the patient was neutropenic at 0.1. That was informed to the patient by the GP. The GP did not let the chemo unit know. So we've got a patient out there, not very well. 7 days post chemo, call from patient's husband. Patient continues to have diarrhea and feeling unwell. They've asked to come straight in to the hospital. The observations were reasonably okay in the fact that they were apyrexial but tachycardic. And they were seen by the medical team and reviewed. So what do? We've got diarrhea, we've got nausea, patient unwell, newts were reasonable at time. We were still unaware what the actual neutrophils were because we hadn't looked. Prophylactic Cipro given, and Tazogen if they spike. And neutrophils were not, the neutrophil count to be known from 2 days ago. When the blood results came back, it was 0.0. They were admitted to the ward being neutropenic but not septic. Ward round by different medical consultant. It's always good to have a fresh pair of eyes. Their impression was neutropenic sepsis. They needed Tazogen prescribed at a regular medication with no initial SACT dose. That ward round took place in the morning. It was not picked up till the midday drug round. And I think that's quite complex. People are so busy on the wards these days that actually it's very rare for a nurse to attend a doctor's round. Call me old-fashioned, but I think it's a great source of information. But there are some people that don't actually do that, or some areas that don't do that. At this point, the patient had a low blood pressure. They were pyrexial, very little output. Were you going to give them Gen? And this turned into severe sepsis and very, very much life-threatening. They were transferred to ITU. That was the outcome. And it actually was very sad because this patient was neoadjuvant. I think huge amount of learning from it, from documentation, observations, recognising that deteriorating patient. And as we've heard from a previous scenario, diarrhea isn't just diarrhea, is it, when it's chemo? It really is an alert in itself that there's a problem. So I think lots of lessons learnt there from a potentially well patient but being unwell. And actually, although she looked dehydrated, she was a bit more than that. So it is really what you see is not what you're getting underneath. And that's why your assessment and managing these side toxicities is so, so important. So assessment and management of the patient receiving SACT is critical in the care of the patient receiving the right treatment in the right place under the right team. We need to be getting it right. We get it right most of the time, not all the time. And it needs to be a collaborative approach. Don't ever think that you're being silly trying to escalate it to somebody and that they are going to think that you must know. We don't. Patient safety is utmost. If in doubt, always seek help. And I would say from an assessment point of view, I would overestimate a problem than underestimate it. It's a lot easier to get yourself out of and to manage. Early treatment has a greater result in patient continuing treatment, so they can get through their cycles of treatment and less likely to be admitted to ITU. As in that scenario, that patient was neoadjuvant. They were just meant to have a bit of chemo, surgery, few chemos after, happy long life potentially. I know it's the esophagus, but there was some longevity there for that patient. Did we achieve that? No. A bone of contention to all of us is actually if we can keep the patient out of hospital or limit their stay, it reduces length of stay in hospital. It's beneficial to NHS organisations from a financial basis. We're all pushed for beds. They want more money. Every NHS trust is in deficit. And again, going back to those new haematology NICE guidelines about the advanced clinical training for nurses managing this cohort of patients, we need to be looking at our training needs for our nurses, whether they be band 5s, 6s, 7s, and even us at 8s really, about keeping those skills really in the forefront about patient safety, assessment, managing those, because it's not going to get any easier. Thank you. Any questions? And lots of references. If anybody wants to sit and read and get bored during the evenings, there you go.
Thanks, Emma. Don't disappear, so we will definitely have questions. That was a very vibrant.
Sorry,
talk. No,
that woke you up, didn't it?
Good after lunch. Keep it going. I think your talk and Simon's talk this morning have really highlighted the need for expert knowledge, and both you and Alice talking about your practice strikes me that there are these opportunities, these windows of time that we're missing, and patients aren't being picked up and escalated appropriately, resulting in patient death, which is preventable. We will value from those lessons that you've had from your practice. So thank you for sharing that. So has anyone got any questions for Emma?
Oh, that's all right then. Just remember to document your news and your UCONs if you're using it, and in the notes. Yes.
I just had a question. I work on the oncology. An idea of how that training looked for kind of nurses assisting us with assessment.
Good question, really, because actually there are modules for advanced assessment and symptom management, but I think with the new guidelines, I think it's something that nationally that is going to have to be looked at. UCONs, I'm sure we've been putting. I think one of the best ways of actually doing it is from simulation. When you've got your when you've got your dummy patients there and you're given a scenario. You can do your modules in assessment and symptom management. I have to say they are very useful, and they do actually pull you back into trying thinking through everything in a very systematic way. And I think that has been, for me, when I've done it, is an actual really valuable tool in don't go like that, but actually think, right, okay, this is what I got, this is where I am. Let's start at the very beginning, as the song goes, and you do really kind of pull your train of thought down. And with that, it gives you the confidence to know that you've actually done a thorough assessment of that patient. And the other thing I would say is once doing that assessment, you're kind of getting a really good gut feeling. And, and to me, we should always have a bit of a gut feeling anyway. But yes, I think the advanced assessment and symptom management skills will need to be looked at from a modular point of view. And it's something that in-house training needs to focus on as well, looking at these new guidelines.
Just so there are lots of opportunities for advanced patient assessment and advanced history taking. So do you want to say anything about that?
Because I lead that module, but I think that those of you that have done it hopefully will agree that it is fundamental, really. The recognition of some of these situations is paramount. So taking an accurate history, whether it be focused or a general history if you're in the emergency department, and actually assessing your patients is what gives us the power to make those decisions that escalate care effectively. So we've always got space. It is very, very popular. But it is a very intense module, but you'd be welcome to inquire if you'd like to have more information about it.